Welcome back to this next video in which we are discussing cardiac arrhythmias. Okay, so we're now going to move on to discussing AV nodal block, which is often simply called heart block. So if you hear someone referring to heart block, generally they're talking about AV nodal block, although more correctly we should say AV nodal block. Okay, so throughout this video we have been categorizing arrhythmias into supraventricular arrhythmias and ventricular arrhythmias. Now I have left AV nodal block out of that categorization because I think it's best discussed right at the end along with bundle branch block. Now really what AV block bears most similarity to in terms of arrhythmias is, in terms of what we've already discussed as well, is the starting stuff that we discussed about sinus bradycardia and sinus tachycardia. So remember, right at the start, when we were discussing supraventricular arrhythmias, we discussed arrhythmias that are caused by problems with the sinoatrial node. Now, what we're about to discuss, AV nodal block and then bundle branch block, these two topics you should think of as going alongside that initial topic of arrhythmias that arise because of problems in the sinoatrial node. And all the other stuff that we've discussed in between, all of that is quite different from this stuff, because this stuff about the sinoatrial node, this stuff about the atrioventricular nodal block, this stuff about bundle branch block, this is all problems with the heart's conduction system for electrical signals. Okay, so these are all arrhythmias that arise because of problems with the heart's electrical conduction system, whereas all the arrhythmias that we've discussed in between, such as atrial ectopic beats, atrial flutter, atrial fibrillation, then what do we have? We had atrioventricular nodal re-entry tachycardia, we had atrioventricular re-entrant tachycardia, we then have ventricular ectopic beats, ventricular flutter, ventricular fibrillation, and finally Torsades De Pointes. All of those arise because certain portions of myocardium are gaining the ability to generate electrical signals that will spread to the entire myocardium, which shouldn't have that ability. Okay, so all of those can be categorized together as problems that cause a certain portion of myocardium to gain the capacity to actually generate electrical signals, whereas the topic that we're now discussing, the two topics we're now going to discuss, along with the initial discussion of sinoatrial nodal problems, those all come together because they're all problems with the heart's electrical conduction system. Okay, so that's another way of categorizing the arrhythmias. I'm just trying to make it so that it makes sense in your head so that you can categorize the arrhythmias. Because all of the arrhythmias that we've discussed in between about cardiac tissue gaining the ability to generate electrical signals, that's all been about ectopic foci, re-entrant loops, and then finally the triggered activity. Those were the mechanisms underlying all of those arrhythmias. Okay, now the mechanisms underlying AV nodal block are just going to be problems with the AV node, damage to the AV node. Okay, so let's actually begin discussing AV nodal block then. So to discuss this, I'm going to need a picture of the heart. So I think the first thing I should start by doing is just drawing out another picture of the heart's endogenous conduction system. Okay, so here is our normal cross-section of the heart. Here then is going to be the right atrium, here is the left atrium, here. Then we'll have the two ventricles, here is the right ventricle, like so. And here is the left ventricle with the interventricular septum in between the two. Okay, so let me firstly just put on the atrioventricular septum, this fibrous insulation preventing electrical signals from the atria propagating down to the ventricles. And now let's mark on the sinoatrial node initially. So here up in red, this can be the sinoatrial node. Then let's put on the atrioventricular node, which is the one window in a healthy heart that doesn't have an accessory pathway between the atria and the ventricles. And then let's put on the the internodal conduction pathways, the anterior one, the middle one, and then the posterior one, and then we'll have the interatrial conduction pathway. Let's also add on the ventricular conduction system, so the bundle of His, then the right bundle branch here, and then the left bundle branch in orange as well. Okay, so there's my picture of the heart's conduction system then. So now let's discuss AV nodal block. So there are 3 different severities of AV nodal block. First degree AV node block or first degree heart block, second degree AV node block or second degree heart block, and third degree AV node block or third degree heart block. Also, you can call them primary, secondary, and tertiary AV nodal block. Okay, so we're going to go through each of these, and by the way, the severity gets greater as you go down. So first degree heart block is the least severe, going down to third degree AV node block being the most severe. So let's start off by discussing first degree AV nodal block. So what goes wrong in first degree AV nodal block? Well, very little really. It's not particularly severe first degree AV node block. What happens is the AV node takes longer to conduct action potentials from the atrial side to the ventricular side, and that's it. That's what happens in first degree node block. Okay, so the sinoatrial node up here will generate an electrical signal, normally at 1 every 0.8 seconds or thereabouts. It'll make its way down to the AV node, and the AV node has to conduct this electrical signal from the atrial side to the ventricular side. And if you are suffering from first degree AV nodal block, it will take longer for this electrical signal to conduct from the atrial side to the ventricular side. That's what first degree AV nodal block is. So let's think about how this is going to appear on the ECG. So remember which portion of the ECG actually corresponds to the electrical signal propagating through the AV node. Well, that's that interval between the P wave and the QRS complex. So if we're suffering from first degree AV nodal block, that interval is going to be lengthened. So let's just start drawing the ECG here. So here we have the P wave, which corresponds to the electrical signal propagating down the walls of the atria. Then we have this flat portion where we're at 0 electrical potential difference between the 2 electrodes of the ECG. Okay, and this is now going to be lengthened because this portion here is where the electrical signal is propagating through the AV node and then the ventricular conduction system before it's actually been released on any of the ventricular cardiomyocytes. Okay, so this portion might usually end here, but if you're suffering from first degree heart block, it might go all the way on to here. Then the QRS complex will be normal, okay, because after the AV node, everything's fine. So here is our Q, R, and then S wave, and then after that we'll have a normal ST segment, and then we'll have the T wave representing ventricular repolarization. Okay, so a prolonged period in between the P wave and the onset of the QRS complex, that is how first degree heart block or first degree AV nodal block is actually going to look on an ECG. Now, there isn't really a term or a agreed upon name for this interval between the P wave and the QRS complex. Instead, there is a term that everyone uses for the interval from the start of the P wave to the start of the QRS complex. We call that the PR interval. So we will use this terminology to describe how the ECG is changed, and we will say that the PR interval is lengthened in first degree heart block or first degree AV nodal block. So that's what first degree AV nodal block looks like, and this doesn't cause any sort of problem at all really, okay, because it's not even going to lead to bradycardia, because all of the electrical signals are actually getting from the atrial to the ventricular side. They're all being conducted, so it's not going to lead to bradycardia. All that this is going to mean is that it takes a little bit longer for the ventricles to contract after the atria contract. So there's a little bit of a bigger gap between the atria contracting and the ventricles contracting, but that's not too big a problem. Okay, so first degree heart block or AV nodal block is usually asymptomatic, and it might just be something that's picked up when you're having an ECG for some completely other reason. Okay, and the clinician will just notice that you've got a bit of an extended PR interval and will say, oh, look, you've got first degree AV nodal block. Okay, right, so now let's talk about second degree AV nodal block, which is a little bit more severe. Now, there are lots of different types of second degree AV nodal block. So there's what's known as Mobitz type 1 second degree AV nodal block, Mobitz type 2 second degree AV nodal block, and then finally there's one that you could really call Mobitz type 1 or Mobitz type 2, and that's therefore called 2 to 1 block instead of calling it Mobitz type 1 or Mobitz type 2. Okay, so let me show you this. So, second degree AV nodal block. So we'll firstly talk about Mobitz type 1 second degree AV nodal block. Okay, so let me firstly describe what's actually going to happen to the AV node in the case of Mobitz type 1 AV nodal block, well, second degree AV nodal block, and then we'll actually talk about what the ECG will look like. So in Mobitz type 1 second degree AV nodal block, the AV node is going to progressively take longer to conduct the electrical signal from the atrial to the ventricular side until eventually it will just not bother doing it at all. It will block the electrical signal propagating from the atrial to the ventricular side. So let me describe this to you. Let's, for instance, let's say, let's start from the beginning. So the sinoatrial node will send the first electrical signal down, it will propagate down to the AV node, and the AV node will conduct it in a certain amount of time through to the ventricular side, and then ventricular depolarization and contraction will ensue. On the second time, when the sinoatrial node sends its second electrical signal, it will get down to the atrioventricular node, and this time, the atrioventricular node, if you're suffering from Mobitz type 1 second degree AV node block, will take longer to conduct it than before. Okay, so it's getting progressively longer, but it will still get it through. It will arrive through on the ventricular side, it will just take longer, and then of course you'll get ventricular depolarization and contraction. And now, the third time, the sinoatrial node will send its electrical signal down to the AV nodal conduction portion, and now it will block it altogether, it won't go through at all. So in Mobitz type 1 second degree AV nodal block, the PR interval gets progressively longer in the ECG until eventually it skips the QRS complex and the T wave completely because the electrical signal hasn't actually been conducted through the AV node. Okay, and it might not occur just after 2, it might not occur on the third one, it might have required a few more, so it might have been the 5th or the 6th. You know, I was just doing the third one being obliterated or being blocked because I was lazy, I didn't want to have to go to the 5th or 6th or 7th. Okay, so to draw an ECG then for Mobitz type 1 second degree AV nodal block, we'll again do the example that I've talked about because I don't want to have to draw a really long ECG trace. We'll have the third one blocked. Okay, so here's the first one, so here's the P wave, a nice normal PR interval here. This interval between the P wave and the QRS complex is normally lengthed. Then we have our QRS complex, like so, the ST segment, and then the T wave. And then we'll have another ECG trace here, so here comes the second electrical signal, so P wave, ventricular depolarization, and now this portion between the P wave and the QRS complex is lengthened, so the overall PR interval is also lengthened. Then we'll have the QRS complex because it has eventually conducted it, okay, the ST segment and then the T wave. And then on the next one, you're just going to get a P wave and then nothing. Okay, the QRS complex won't be there, the T wave won't be there, it just blocks it. The electrical signal is not conducted through the AV node. And then on the one after that, the fourth electrical signal, that will go back to being like this first one, so it'll just go round and round in this rhythmic way, okay? And every so often, once the PR interval is lengthened up enough, then the next one along won't actually be conducted through the AV node. So the PR interval in Mobitz type 1 AV nodal block is going to get progressively longer with concurrent cardiac cycles until eventually the electrical signal isn't actually conducted through the AV node at all. Okay, so that's Mobitz type 1 second degree AV nodal block. Now let me talk about Mobitz type 2 second degree AV nodal block. So now Mobitz type 2. Okay, so in Mobitz type 2 it's slightly simpler. The PR interval remains completely normal for most of the cardiac cycles, but then every nth cardiac cycle you don't actually conduct the electrical signal through the atrioventricular node at all. Okay, so in Mobitz type 2 you have what is known as n to 1 block, okay, where n is some number greater than or equal to 3, some natural number greater than or equal to 3. So it can be 3, 4, 5, 6, 7, etc. If it's 3 to 1 block, then every third beat of the heart, every third electrical signal that comes down will be blocked by the AV node and won't be conducted to the ventricles. If it's 4 to 1 block, then every fourth beat won't be conducted down to the ventricles. If it's 5 to 1 block, then every 1 in 5 electrical signals won't be conducted down to the ventricles, etc. More generally, we have N here. Okay, so I will describe now the 3 to 1 block, because again that's nice and easy to draw the ECG. Okay, so we'll draw the ECG then for Mobitz type 2 AV nodal block. So we'll do 3 to 1 Mobitz type 2 AV nodal second degree block. Okay, so here then is the P wave for our first electrical signal. You'll have a nice normal interval between the P wave and the QRS complex. So here now is our QRS complex, the ST segment's normal, the T wave's normal. Then we'll have the next one along, so here now is the P wave, and this time the interval is not going to lengthen. Remember, in Mobitz type 1, the next second electrical signal, the PR interval, had hugely lengthened. It's not going to lengthen in Mobitz type 2 block. Okay, so it hasn't lengthened. Then what you'll have is the QRS complex here, the ST segment, and then the T wave here. And then now on the third one, you'll have the P wave, but then it just won't conduct through the AV node at all, so you won't then have a QRS complex, you won't have a T wave after that. Okay, it will just remain flat, the ECG trace for that one. And then on the fourth one, of course, you'll then go back to the beginning. So you'll have the P wave, and then it will conduct through the AV node, you will get a QRS complex, and then a T wave, so everything's fine. Okay, so that's Mobitz type 2 second degree AV nodal block. Now clearly, Mobitz type 1 second degree AV nodal block and Mobitz type 2 second degree AV nodal block, these are slightly more severe than first degree AV nodal block, because they are actually going to result in bradycardia, because we are skipping some ventricular beats here. We're getting the atria contracting but not the ventricles, and that will lead to a reduction in the number of times that the ventricles are actually contracting in a minute, and therefore we will end up with a slight bradycardia here. So these are more severe. Now there's one final second degree AV nodal block, which is 2 to 1 block, which you can't actually decide whether to call this a Mobitz type 1 or a Mobitz type 2. So let me describe 2 to 1 block to you, and then I'll explain why, well, hopefully you can work it out for yourself, why this could be called Mobitz type 1 and Mobitz type 2, which is why we don't consider it as either, and we consider it as a separate one in its own right. So this is just like Mobitz type 2, but we're going to have every second beat not actually conducting down to the ventricles. Okay, so it's going to be very nice and easy to draw an ECG for this one. So here's the first electrical signal, the first beat from the sinoatrial node, and this is completely normal. So it completely got conducted down to the ventricles. And now let's have the second beat from the sinoatrial node. Here's the P wave, so we got atrial depolarization, but then it's just not going to conduct down to the ventricles at all. So you'll just skip all of the remaining portion of the ECG, no QRS complex, no T wave, and then we'll have the third beat, which will go back to normal, so you'll have a P wave, a QRS complex, and a T wave after that. Okay, and then the fourth one, again, it will be blocked by the AV node, it won't be conducted down to the ventricles. Okay, you'll just have atrial depolarization represented by the P wave. Okay, so that's 2 to 1 block. Now clearly, that could be considered a Mobitz type 2. Why then can it also be considered a Mobitz type 1? Well, because Mobitz type 1, what happens? The PR interval lengthens on progressive cycles until eventually it drops. Okay, until eventually it gets so long that it drops. Okay, you could argue that this is Mobitz type 1, because in the second beat it's lengthened so much that it's dropped. And that's why you could call it Mobitz type 1 as well as Mobitz type 2. So I hope you understand why 2 to 1 block could be seen as being Mobitz type 1 and Mobitz type 2, even though instantly you might think that's just Mobitz type 2. But because it could also be considered Mobitz type 1, we call it a separate second degree AV nodal block and consider it separately here. Okay, right, so that's 2 to 1 AV nodal block. Okay, finally, what I'm going to talk to you about, and I'll come back to the treatment if necessary. Usually second degree heart block, it isn't fully necessary to have treatment for second-degree heart block. Third-degree heart block is the one where you do need treatment. So I'll talk about treatment right at the end. Okay, so now we'll talk about third-degree AV nodal block. Okay, so third-degree AV nodal block is where the atria and ventricles are now completely separated from one another. Okay, it's also called complete and utter block. So if someone talks about complete heart block, then they're talking about third-degree AV nodal block. Okay, and basically, it's as it says. The atrioventricular node is just not going to conduct electrical signals at all from the atrial side to the ventricle side. So what will happen is the sinoatrial node will be sending off electrical signals. So going back to the picture here, sinoatrial node will be generating electrical signals all the time. These electrical signals will be propagating down to the atrioventricular node. However, the atrioventricular node is just not going to conduct any of them down to the ventricular side. Okay, so you get complete dissociation of the atria from the ventricles. They're completely now cut off. Now, what's going to happen then? Do the ventricles just stop contracting altogether? Well, no, and remember why. The His-Purkinje system, the cells of the His-Purkinje conduction system in the ventricles, they do have the capacity to generate electrical signals in a pacemaker way. They can generate electrical signals in a rhythmic way. They do have HCN channels and are capable of actually generating electrical signals at a certain rate. However, this rate is very, very low compared to the rate at which the sinoatrial node cells would generate electrical signals. So remember, it goes like this as far as pacemaker tissue in the heart is concerned. The sinoatrial node cells, they generate electrical signals at the fastest rate, at about 75 per minute. The atrioventricular node is then below the sinoatrial node. It can, if you take it out and don't have it in overdrive suppression, it can generate electrical signals at a rate below the sinoatrial node, but above the His-Purkinje system cells, okay? And then the His-Purkinje system cells, if you take them out and put them on a plate, they will generate electrical signals at a rate even lower than that. So I'll just put this here. So the sinoatrial node generates electrical signals most rapidly, followed by the atrioventricular node, and then followed by the His-Purkinje system cells. Okay, so we've lost the sinoatrial node and we've lost the atrioventricular node. The AV node is completely misbehaving, so it's not going to be generating us electrical signals. Okay, the sinoatrial node might still be working, but we can't hear it now in third-degree heart block, so we're now reliant on the His-Purkinje cells. So you will still get the ventricles contracting, but they will contract completely out of rhythm with the atria, so it won't be a case of the atria contract and then the ventricles contract. They'll just be contracting driven by totally different clocks now. So the sinoatrial node will be determining how the atria contract, and the His-Purkinje system will be determining how the ventricles contract. And the ventricles will be contracting far less often than the atria. So actually what you end up seeing on an ECG trace is you get P wave after P wave after P wave, because the sinoatrial node is sending out electrical signals and causing atrial depolarization. So here we have lots of P waves, and then occasionally dotted around the place you'll have a QRS complex, because the His-Purkinje system has successfully generated an electrical signal. Okay, but they will be rare, they will be just dotted around. So the ECG will look like this. You'll have rhythmic P waves, and then dotted around you'll have QRS complexes at a much lower rate, which will be being generated by the His-Purkinje system. Okay, right, so that's what's going to happen then in third-degree heart block. Right, so now let's talk about how we can actually treat third-degree heart block or complete heart block. So complete heart block is usually treated with a fitted dual-chamber pacemaker. Okay, so we've discussed single-chamber pacemakers already in this video. Let me now discuss dual-chamber pacemakers, because we haven't discussed these so far. So we're going to need a dual-chamber pacemaker here, because we need to have a way of determining we need to have a way of controlling when the atria are contracting and also when the ventricles are contracting, and now there's no connection between the two, so we can't control the way the ventricles are contracting just by controlling the way the atria are contracting. Okay, so this is why we're going to need a dual chamber pacemaker. Dual chamber pacemaker this time. Okay, so the idea is exactly the same. You'll have a little device that is implanted under the skin, and the way the electrodes will get into the heart is the same. Okay, we will put the leads going into usually the left subclavian vein, and we'll feed them into the left brachiocephalic artery, into the superior vena cava, down into the heart. And we'll put one lead into the tissue of the right atrium. So if I go back to my picture of the heart up here, we'll put one lead to control when the atria are going to contract, and we'll have one lead going into the right ventricle. So one of the leads will come up and insert into the wall of the right atrium, the other will insert into the wall of the right ventricle here. Okay, and the idea now is that the pacemaker is going to then generate electrical signals like the sinoatrial node would. So it will generate an electrical signal up in the atria here, and it will take over for the sinoatrial node, and the atria will contract. And then the device can then say, shortly after this one's been stimulated to contract, I want the ventricles to contract. So it can do effectively what the normal conduction system of the heart would do, and get the ventricles to contract shortly after the atria. So it will then deliver electrical excitation to the ventricles, and will get ventricular contraction after the atrial contraction. So in a dual chamber pacemaker, you have a lead going into the atria, a lead going into the ventricles. The lead going into the atria will determine when the atria contract, a lead going into the ventricles will determine when the ventricles contract, and the pacemaker will then make sure that it stimulates the atria, waits a little bit to allow atrial contraction to occur, then stimulates the ventricles, and will get ventricular contraction just after atrial contraction. So it is going to get the heart to contract in the correct order, with the atria contracting first and then the ventricles contracting afterwards. Okay, and that's usually the treatment for third-degree heart block. Usually second-degree heart block doesn't actually require treatment, but if it does require treatment, you could treat it with a dual-chamber pacemaker. Potentially what you can do is ablate the atrioventricular node and then go over to a dual-chamber pacemaker. But obviously you don't really want to have to do that. You'd rather try and keep it as little treatment as possible. Obviously, pace and ablate is a reasonably extreme treatment to use. Okay, but certainly for third-degree heart block, we're going to use a dual-chamber pacemaker.